Edith Johnson, and this is Humans of Clinical Academia, a Manchester Catalys podcast. Every episode, we invite a leading clinical academic to share 5 images that reflect key moments in their lives and careers. We do this over a drink of their choice. We describe these images in the audio version of the podcast, but head over to our YouTube channel and our Instagram page if you want to see them for yourself. My guest this week is Professor Dawn Dowding, Chair in Clinical Decision Making. Dawn completed her registered nursing training at St Bartholomew's Hospital and a Bachelor of Science degree in Psychology with Nursing at City University London. She then went on to complete a PhD in Psychology and Nursing at the University of Surrey. Since then, Dawn has published 150 peer-reviewed research articles. She has been awarded research funding from the UK National Institute for Health Research, the Burdett Nursing Trust, and the US National Institute of Health. Through her career, Dawn has held professor positions in both the UK and the US, including spending 5 years at Columbia University in New York. She is now back in the UK and based at the University of Manchester, where her current research interests are clinical decision-making and digital health. Professor Dawn Dowding, welcome to Humans of Clinical Academia. Today we're doing the podcast over an Americano with oat milk. Good choice. When did you take up oat milk as an alternative to cow's milk?
I was trying to think back as to when I did, because I've been drinking Americano with oat milk for at least 7 years, if not longer. So I think it was the last couple of years I was in New York where we discovered it as an alternative to cow's milk, decided it made our coffee taste much nicer. So I've been a convert ever since, and since then have converted to being a vegetarian.
Oh, wow.
And have spent a bit of time being a vegan as well. So yeah, it's a long while now, and I can't actually now drink cow's milk in my coffee anymore.
It does taste different, doesn't it?
Yeah.
It's noticeably different taste. Okay, so let's start today with your research and strategic work in digital health. You are a co-chair for the Digital Nursing Forum for the Royal College of Nursing. You're on advisory panels for the Chief Nursing Informatics Officer for England, and you're on the DHSC AI in Health and Care Advisory Group, amongst other things as well. So all of this work, why is it important to you?
So I guess I think it's really important because there's very few of us who work in digital nursing research in the UK. There's a growing number of individuals working at strategic level in digital nursing across NHS and other organisations. But I've realised through my research career that one of the biggest issues we have with digital implementations and actually getting our workforce to use digital technology efficiently is that quite often nurses aren't in the room when those systems are being procured and implemented. And it's really important, therefore, that we have that leadership at strategic level to advise and give a voice to nurses in a variety of different fora. And certainly the work with the RCN and with the CNIO in particular is helping to give some insights into what's happened in other countries, and also where the research evidence is and how that can help inform strategic levels going forward. So I think it's almost like throughout my career I've done all of this research, and now I feel like I can actually use that to help inform things and influence things at policy and strategic level, which is really important because with the government's push on digitisation of our health services, the need for this is even greater than it already has been, particularly with the implementation of AI. And if we're going to be successful, then nurses, largest part of the healthcare workforce, actually need to be brought along behind us. So actually having that strategic level voice means that hopefully that trickles down and helps us to help the workforce transform, because that's the only way that we're going to end up working in an efficient, effective health service with nurses that actually have systems that are usable.
You mentioned just then that you think AI is a really important area that nurses should be involved with at the moment. What are the challenges that you see on the horizon?
Well, there's all sorts of challenges. I mean, I think the issue is that we have AI in some areas of healthcare practice. We need to be able to transform that technology so that it helps support clinical practice in all sorts of areas. But in order to do that, we need the underpinning data and infrastructure to do it. So I think we as a workforce need to understand what goes into good AI. What does good AI look like? How can it help solve some of the problems that we're facing in practice? And then how can we help influence that? So there's a variety of different issues. And I do get concerned that we're focusing on AI without actually realising what the underlying data infrastructure realities on the ground are for our nursing and midwifery workforce and AHP workforce actually, and listen to them to help make sure that the technologies that we produce actually produce efficiencies for them going forward. So that's my main anxiety and concern really, that we're not really as a profession engaging with it and thinking how do we embrace it and make it work for us rather than being scared of it.
I guess taking a step back, you're doing so much strategic work and it's so impressive, the kind of policy influence. If there is a clinical academic who's maybe earlier in their career, who's listening to this and thinking, that sounds amazing, I would love to be able to have that kind of influence in my research, to have that kind of influence, what advice would you give them?
That it takes a really long while to get to this point. I'm sure we'll talk about this in the podcast, but I've been doing this since 1992, so I'm not, and it's only since I've come back from the States that I've been involved in this sort of policy work. So that's taken 25 years. It doesn't happen quickly, and some people end up doing it more quickly in their careers than others. But I think it's really focusing on developing your research, developing things that you find of interest, and if they're important to the system, then at some point it will be important to the policymakers. So I think it's one of those things. It's like I'm at the tail end of my career now, so it's not, I wouldn't have been doing this as an early career academic. So it's just seeing that there are these opportunities as you get further down the line, I guess.
No, I love that. So your message is it's about persistence, it's about pressing forward, it's about patience, and it's about continuing to do good research and promoting that. I mean, I think that's fantastic and really encouraging, actually. So let's pause and take a look at our first photo, which shows a book of a nurse.
Yeah. So this is a book called Sue Barton's Staff Nurse, which was one of a series of books that I discovered in the school library in my first year at high school, senior school. So I would have been about 11 or 12 when I discovered the Sue Barton books. And I read all of them. There's a whole series. There's not a huge number. I think there's 6 or 7 that takes her all the way through from being a student nurse to staff nurse to matron and superintendent nurse and community nurse and all sorts of things. And I read them voraciously. I was a very voracious, well, I still am a voracious reader. Fell in love with the concept of being a nurse and decided at that point that's what I wanted to do. So I think Helen Doyle Boylston, who was the person who wrote the Sue Barton books, has got a lot to answer for, because once I read those, I wasn't going to be diverted. I was just going off to be a nurse.
Yeah, that's fantastic. So what was it about the picture of nursing in those books that kind of pulled you in?
I think it's because it was the connection with people and looking after people. I was reflecting, I realised when I pulled out the photo of this book that it was actually written in the first one was written in 1937, I think, which I guess when I was reading this in 1979, 1980, would have made the depiction of nursing even then slightly old-fashioned and a bit glamorous, and she was like married to a doctor and did all sorts of wonderful things with patients. But I guess it was that human connection and the caring for people. I've sort of realised over my life that I actually like people. I like talking to people. And there's something about looking after people when they're at their most vulnerable, which I sort of found that attractive. It's very hard to put a feeling on it, but it was very definitely something about that communication of what she saw nursing to be at that point in time, which I found quite attractive.
That's amazing. It really goes to show, doesn't it, the power of, I suppose, stories getting out there and how they can influence especially young people. Your route into nursing was unusual. You did a joint degree of psychology with nursing at undergraduate. So you gained both a degree in psychology and at the same time and afterwards were then able to continue training to register as a nurse. What led you to take this route?
So I did. I was doing my A-levels in the mid-1980s, and at that point in time, only around 5% of the population went to university, and I had very good predicted grades at A-levels, so there was an assumption I would go to university, and the perception was that nursing wasn't a degree-level profession. Most of the offering for nurses was to go to hospital-based colleges of nursing to do your nurse training. And I went to a careers fair with my father and went to talk to the person on the nursing stand. And when she found out what my predicted grades were, basically gave me some literature on how to do a degree in nursing. So at that point, I had support from my family because I was going to go off and do a degree instead of going off and doing nurse training. And I basically ended up doing the course I did because I didn't do A-level biology, so I couldn't get into some of the degrees in nursing. So Manchester, which is where we are now, actually had one of the first nursing degrees in the country. I couldn't apply to Manchester because it needed an A-level in biology, and I also couldn't apply to Surrey, which was the other place that did a degree in nursing, where I did my PhD, because, again, you needed A-level biology. So I ended up applying to a few other courses. I ended up doing the course I did because it was the best of both worlds. I did my nurse training alongside getting a degree in psychology over 4.5 years, and we sort of split between the college at nursing and the university. So I sort of, and I was quite pragmatic really. I was basically thinking, well, I'll train as a nurse, so I'll always have a qualification that I can use, but also a degree in psychology is a sort of more recognised degree than a degree in nursing. So really that was why I ended up there. And to be honest, I walked into the Barts courtyard, and if anybody's ever seen the courtyard at Barts, it's very beautiful. It's got a fountain in the middle. It's surrounded by very old buildings, and I just fell in love with it. So I decided I was going there.
That sounds great. Since that time, nursing has changed, so it is a degree as standard. How do you think that's influenced the experience of prospective nurses?
So I think it's a really good thing. I certainly think we need nurses to be curious and have a good grounding in evidence and research in order to do the job that they need to do now. And I think sometimes people forget that the people that we look after now in healthcare are very, very different to the people I looked after when I started my nurse training. And actually there's now an awful lot of research evidence to show that there's a correlation, an association, a very strong one between the academic level of the people that care for you. So the organisations that have nurses with degrees and higher levels of training and education end up having lower mortality rates and better patient safety for patients. So I think it's good for the profession. I think it's good for people doing it, and I think it's good for patients. So I'm really pleased that that's what's happened over the course of my career. I mean, when I started my nurse training, the average age of the people I looked after was around mid-60s. It's now in your early 80s. The people that we were looking after on the wards wouldn't even get into hospital now. There's people on the general medical wards that when I did my nurse training would have been in a high dependency unit. So the level of acuity, the level of complexity of the people we look after has changed, which means that you need a workforce that is better educated.
Let's move on to our next photo. This shows the cover of a journal. Can you tell us more about this?
So this is a research report which was published by the Royal College of Nursing as part of their series of research studies that they commissioned starting in 1973. It's called Ready for Report Nurse. So I can remember when I did my nurse training at Barts and my degree at City, reading this research report as part of the studies that we did in terms of looking at nursing research and evidence. And at the time, there wasn't that much research in nursing, and the RCN research reports were one of the main sources of evidence. And this is only one of a number of studies that they published. The reason I've chosen this particular one is because when I went off to do my PhD at Surrey University, I ended up doing my PhD looking at nurse handovers and nurse reports. So this was the seminal piece of work that informed that PhD work. So it's like I can remember reading it in the library at Barts, and then I went and dug it out again when I did my PhD, and I actually now have a proper copy of it in our attic somewhere. So yeah, it was just that. It was really, I think, I sort of, in retrospect, realised that I'd always been attracted to research. I loved the research part of my psychology degree. I found the research studies that had been done in nursing really important and interesting at the time. And I guess it was just that made me think about doing research in the future.
Mm. Do you think that your dual kind of undergraduate training, both psychology and nursing, increased the likelihood of you taking a research route?
Yeah, I do, because I think part of the psychology degree was very research. I mean, psychology is very research focused. So we did modules on experimental design, research methods, statistics. I got used to having to do my own SPSS programming to be able to do the statistical testing I needed to do. And part of that degree was actually doing small research projects and analysing the data. And I think I sort of found it interesting and was actually naturally quite good at it. I got my best marks in the research modules, really enjoyed doing my dissertation research. So I think it was, for me, it was a right fit. And I very, very much realised early on that I probably enjoyed the research side of things slightly more than clinical practice, even though I loved clinical practice and I loved talking to people and I loved looking after people. I did sort of realise that I did have that sort of natural bent towards research as well.
Mm. And how did you take that first step into research?
So I worked for a couple of years in practice. So I after I qualified, I worked for a year at Barts on what was then the acute admissions ward. It would now be the medical acute unit, I think. And then I moved to St George's in Tooting, where I worked on the intensive care unit. So I did very acute sort of, I guess, technology-supported nursing. And I got to a point where I had to make some choices. So I'd been an ICU nurse for about 8 or 9 months, and at that point I could have decided to go off and do the EMB 100, which at the time was the training course you did to qualify as a specialist ICU nurse. But I sort of realised that I didn't, although it was interesting work, I didn't really enjoy ICU nursing. So I had to make a choice about what I would do next. And I just happened to come across an advert, I can't even remember where I saw it now, that was seeking a research assistant to go and work at Surrey University on a project looking at nurse assessment. And they were looking for somebody who had a degree, who was a nurse ideally, who could do the work as a research assistant on this project. And I looked at it and I went, well, I think I can get to Surrey University and commute. It was quite a long way away, but I think I can do that. Sounds really interesting. I'll just apply. What's the worst that can happen? They'll say no. I haven't lost anything. I applied for the job and got it.
You began your career researching into how decisions are made in nursing practice, but more recently you've moved into digital health. How did that transition happen?
Yeah, so it's quite an interesting story, really. So yes, I started off working on this project at Surrey looking at nursing assessment, which was very actually psychology focused. We were trying to figure out what information nurses use to assess patients and the processes they use to do those assessments. And alongside, I was doing my PhD looking at nurse shift reports and looking at the effectiveness of a communication in those shift reports and looking from a cognitive psychology point of view how we use information and how we process it. So I sort of had that sort of grounding, I guess, in the psychology of decision making. So the first few years after I got my PhD, I had a couple of studies looking at specifically how we use information in practice and how we make decision making, and sort of thought, well, that's all very well and good understanding that, but we really need to figure out how to help people and support them make decisions more effectively, or use information more effectively to do that. So then I started doing some work designing, implementing, evaluating decision support tools. And in between, I moved from, I'd sort of gone from Surrey up to Scotland, and then at Stirling University, and then moved down to York University, where there was a whole group of us who were looking at decision-making stuff. And that was where at the time the Centre for Evidence-Based Nursing was. So there was this whole sort of group of us looking at information use, how you can incorporate research evidence into decision-making. And there was a call came out from what was the SDO at the time, interested in computerised decision support in nursing. So we applied for that funding and got it as a collaboration between us and the University of Southampton. And that was my first foray into looking at computerised decision support and systems. And at that point, they were quite new, standalone sort of systems. And it was really that research study that set me off in the field of digital technology, informatics, whatever you want to call it. I went to a nursing informatics conference to present some of the findings of this work, and suddenly went, I found my people. I found the people who understand what I'm talking about, and I've never looked back since then. And really, it's gone from decisions. So there's a whole theme throughout my work, which is looking at use of information and supporting decision making in practice. But as the world out there has changed from paper to digital, the research has had to change to look at digital innovation and digital transformation and how we use digital technologies in practice. So I guess the message is that you have to be a bit flexible along the way. I could have stuck to looking at decision making, but actually in reality it's much more what's happening out there in practice now is that we're implementing a whole load of digital tools, and we really need to understand what impact that is having on our practice and how people are using them, and can we design them more effectively. So that's how it's happened, really.
So it sounds like the message from what you're sharing is that there is a need for researchers to keep moving where the rest of the world is moving, to not kind of have a hobby horse, but to kind of be outward looking and aware of the world around us. Yeah,
and just being a bit flexible, because I think it also, as to be a successful researcher, you actually have to be quite pragmatic. So it's looking to see where the world is moving, keeping an eye on policy and what's happening at a policy level and at a government level, looking at what's happening in practice, talking to practitioners, finding out what the clinical issues and problems are that they're facing. Could your research help with that? So it is being flexible and being a bit outward facing and accepting that over the course of a career, where you go might change, because actually policymakers put research funding into the places where they think it's going to have the best bang for their buck, and that, so you have to move with that if you're going to get funding for your research. You can't just be staying, I could still be doing research on decision making, but I don't think anyone would fund it anymore. So it has to be moving with the times in terms of where the funders and the strategic policy people are going.
It's time for our next photo. Dawn, could you share this with us? It's a picture of you, and I think it's to do with your Harkness Fellowship.
Yeah, so this is a photo. It's taken as a screenshot from the Commonwealth Fund website, and it's what I looked like at the time 15 years ago when I went off to do my Harkness Fellowship in Healthcare Policy and Practice. So the Harkness Fellowships, those people who don't know, are a year-long fellowship offered by the Commonwealth Fund of New York, where you can go over to the United States and do a piece of research which is relevant to the Commonwealth Fund priorities, and in some area of healthcare policy and practice. So I apply. I mean, there's going to be a theme through my whole career, is that I met somebody who was applying for one of these fellowships when a couple of years before I applied, thought it sounded quite an interesting thing to do, went and did a bit of research, thought that sounds like a really interesting thing to do. I could go over to the States for a year and do some interesting stuff. Luckily, I have a husband who was quite happy to move with me to America. So I applied to the Harkness Fellowship thinking, well, what's the worst that can happen? They could say no. Ended up passing the interview and getting offered the fellowship. So I ended up going out to California, where I did a year-long research study looking at the impact of the implementation of the electronic health record system that was being implemented at the time in Kaiser Permanente, which is a big healthcare organisation, but mainly based in California, looking at the impact on nurse outcome, patient outcomes, and how nurses use the system. So that was actually quite a pivotal moment, I think, in my career for a variety of reasons. Firstly, as I said, it sort of built on the work that we'd already been doing in York, looking at clinical decision support and sort of moving outwards a bit to look at more generally technology systems. It exposed me to a different healthcare system. I was able to do some research out in California that I wouldn't have been able to do at the time in the UK. I took my whole family with me, so we had a brilliant time out there as a family, experiencing a different culture. And I think it just opened my eyes to different ways of doing things, exposed me to different researchers. It was just and also that sort of healthcare strategic policy approach. I don't think in nursing in general we're very good at looking at the bigger picture. We quite often look at what's happening in our own unit or our own ward or our own organisation. Maybe we sometimes consider what's going on a bit national level, but just sort of thinking about things at a health policy level, much more focused way, meeting lots of interesting people from different countries. The Harkness Fellowship is very good at exposing you to different thinking and different ways at that sort of strategic level. So for a variety of reasons, it was a really good experience. And I think that's why I put that photo there, is I think I could have gone two ways in my career. I chose the Harkness Fellowship route, and I've never regretted it and never looked back. It was an absolutely brilliant experience. So, that's why it's there.
And I have to ask, what were the best bits about living in California?
The weather. It was just sunny all the time. Well, it wasn't sunny all the time, but in my head it was sunny all the time. We lived in Berkeley, so it was my son went to this amazing nursery school that was very hippie and he absolutely loved it, and it was just a really, really nice way to spend a year. I spent a lot of time in coffee shops because coffee shops were a thing then. I spent a lot of time in San Francisco, which is a very cool city. It was just a brilliant experience, really.
Mm. So, Professor Dawn Dowding, let's go back to the start. You were born in Hoddesdon in Hertfordshire in the late 60s and growing up there in the 70s. What was that like? It's funny, isn't it? Because your childhood is your childhood. So it's just what I experienced. I mean, I think it was probably now quite a simple experience. I can remember the first time we got a colour TV. That was amazing. I can remember us having the central heating put in the house, because before that we had a coal fire. I can remember the day that we had the house carpeted and we had to sit in the kitchen on the kitchen tables while we actually lived next door to somebody, Uncle Albert, who designed carpets and was a carpet fitter. So he came and fitted all the carpets and the ground floor of the house, and that was a big moment. I spent a lot of time with a tennis ball in a sock playing outside on walls and running around and cycling everywhere. And so I think, in retrospect, it was a very different sort of childhood to the childhood we have now. I don't think that anybody would be happy. We lived in a cul-de-sac, and I spent an awful lot of time with the neighbourhood kids playing hide and seek around the cars and stuff. I don't think we'd be allowed to do that now. And just running off all over the place. Didn't have mobile phones, so we just disappeared off and came back for tea and things. So I actually think that, in retrospect, it was probably quite a good time. Food was terrible, but the other side of it was good. Yeah. This is a good moment for your next photo. Can you describe it to us?
Yeah, so this is a photo that I took a photo of. It's like sitting on our fridge at home. So it's a photo of me and my little sister. So she would have probably been about 18 months, 2 years old. I'd have been about 4 or 5. We're sitting on a bench. I'm holding Ted, my teddy bear, who I still have. So he's very old now. He was given to me by my grandparents when I was a baby. And we're looking to the right-hand side and killing ourselves laughing because we're on holiday in Wales, and my gran is taking this photo. She'd sat us on the bench so she could take a nice photo of us with the Welsh countryside in the background. And at the particular moment in time, Dad was moving the cases into the cottage in Wales and managed to slip over and go sprawling on the floor. So we're actually killing ourselves laughing. And I guess it was just... This photo sat on the bedside, my nan's bedside, ever since it was taken. So when she died, it was one of the things that I took as a memento, and it sits on our fridge now. And I guess it just brings back happy memories of childhood, going on holiday with Nan and Mum and Dad, and just very simple things. Staying in the cottage would have been quite unusual for us because we normally stayed in like static caravans and things like that. And I can remember all of us trying to getting into a mini clubman, so there'd be Nan in the back with the two of us, me mum, my dad, the dog, and then God knows how many suitcases on the top of a roof rack for us to go down to Cornwall or Wales or wherever it is we were going. So yeah, it was just when I was trying to think about something from our childhood, I was like, oh yeah, that's a nice memento, really. Yeah.
No, that's lovely. Moving forwards, you spent 5 years working in the US, specifically this time in New York, not California. What drew you to New York?
Okay, so as part of my Harkness fellowship, obviously, as I said, you make lots of connections. So while I was out doing my Harkness fellowship, I had the opportunity to meet with a large number of academics in nursing informatics out in the States, which is a reasonably established research community. I would have said it's a very strong research community now in the US. So I'd made quite a lot of connections with a lot of people who were doing research in similar areas to me while I was there. I moved back to the UK and went to the University of Leeds, and I guess I'd been inspired by all of that research, and at the time, it was 2010, and in reality, where we are in the UK at that point in time in terms of digitalisation of our healthcare, we were way behind the US. And the sorts of research that I wanted to do and the sorts of research I was interested in were actually almost impossible to do here in the UK at that point in time, given the state of where we were. So it was just one of those things where because I had all those connections and because I had met all of these people, this job came up at Columbia University School of Nursing, which is a joint appointment between Columbia and the Visiting Nurse Service of New York, which has a policy research unit. So it was a joint professorial position, and they'd had real trouble finding anybody to fill it. So one of my colleagues just sent me the job advert and said, I saw this and I thought it might be something that you might be interested in, just given your background, because Columbia University School of Nursing has probably the major research unit for nursing informatics in the US. And I knew Sue Backen, who led that research unit. So I applied for the job, thinking, what's the worst that can happen? They'll say no. Got flown out to New York and had 2 days of... So before I went, I had a couple of sort of video conference interviews with people at the Visiting Nurse Service, people at Columbia University. And then I went out to New York and spent 2 days there and did seminar presentations and met lots of people. And they offered me the job. So again, luckily I've got a very supportive husband and who was very up for moving to New York. He'd lived in New York in the 1990s and was quite happy to go back. So we shifted the whole family and moved out to New York for 5 years. Yeah, so it's just one of those things. I think sometimes you make opportunities happen. It just happened to be connections, and I'd met people and maybe just taking a bit of a risk. And I can appreciate that other people's circumstances might be slightly different to mine, but yeah, that's how it came about.
What are the differences for academic researchers in the US compared with the UK?
It's really different, actually. I think there's some things we do really well in the UK. So patient involvement in research is very strong here. And that sort of emphasis on impact into the healthcare system. The US system is, I would have said, a more traditionally academic model. So so in terms of training to do research, at Columbia we had some doctoral training programs which are funded by the NIH, and they're given to the organisation, and it's a pot of money, and within it you apply for it to train people to do PhDs and doctoral research in particular areas. So we had one on data science and informatics that was led by Sue, and I was a co-director of that for a while. So that meant that we could offer studentships to people who are interested in the area to come and do that research. So it was a lot easier to build up a research team because you had a group of PhD students and a group of postdoctoral researchers all working in the same area alongside a group of academics. So I think that bit is very interesting in terms of training. That's only one route. I mean, obviously they have other ways of people coming to do doctoral studies, but that struck me. In terms of obtaining grant funding, they're very much focused on programs of work. So you would, the sort of traditional route is that you would do your doctoral training, postdoctoral fellowship, build up a small grant, which you would get funded, and which was the sort of priming feasibility work, which we would use to then do a larger grant, and then based on that larger grant, you would have offshoots of work, and you would then apply for research funding to build on that work. So there's much more emphasis on developing a full programme of work over a large number of years in a similar area, and the funding streams are set up to do that. And I actually think that's probably, I've reflected on that quite a bit in terms of coming back to the US. You tend to have quite a spotty research career because it depends on where the funding is and how successful you are, whereas they're very much focused on building on previous work. So I think it's just different. They don't have ref, which means that some of the pressures that we have as academics here are not the same. So I think we can have a debate on whether that's good or bad, but they don't have that whole framework of trying to prove how good your research is. You could just focus on doing good research. And I think that sort of, if you do good research, then you get more research funding and you get good people doing it. So I think they've done something quite right about that, because I'm horrified by the industry around the ref now that wasn't there when I started my career. And I think, I can see why we do it, but at the same time, it eats up a huge amount of time, effort, resource and funding that academics could use just doing research. But that's my own personal view. So, yeah, there's a few different things.
I think this is a good point to look at your last photo. Can you share this with us?
Yeah, so my last photo is of a bag which has Columbia University School of Nursing on it. It's a very posh tote bag, which was one of the things that I was given when I left Columbia and came back to the UK. And I think it probably that was again a big decision point, because I really enjoyed working out in the States, and I got really good experience working at Columbia University. And but our visa was up. I had to make a decision whether to stay or not, and we decided to come back to the UK. So I guess it represents that decision point in terms of, accepting that our little sojourn into the US had finished, and I'm now back in the UK. But yeah, it's quite a poignant one. It's one of the few things that they gave me.
So Dawn Dowding, as we mentioned earlier, you have published 150 research articles. I think a lot of healthcare professionals feel fearful of getting into writing research papers. What kind of recommendations and advice would you have for someone who's just getting into publishing?
So I think the first one is to write and not be scared of it. And I think that there is a huge barrier. There is, I mean, I know personally I prevaricate quite a bit when I'm writing. But at some point I just go, no, I've just got to sit down and start writing. And once you start writing, that's fine, because you can always edit. You can't edit something if it's not on a page. So you have to write stuff to be able to edit it to make it right. I think most of us work in teams, and most of us work collaboratively. So don't think it's just your job and your responsibility to write stuff. Other people are there to help you. So seek help and support. There comes a point where you have to let it go. And I see this quite a bit with people that I supervise and mentor, is that you have to get your head to a point where you accept it's just good enough. It's never going to be perfect. So you make a decision it's good enough to go out to a journal for review. You expect it to come back with comments and insights and suggestions for improvement. I think I was just saying to you earlier, Jude, out of those 150 papers, there is one in that has come back with no reviewers' comments for changes and adjustments out of 150. The normal is it comes back with comments. Sometimes they'll say it's not good enough for this journal, or it's not appropriate for this journal. That's fine, you just send it somewhere else. I can't tell you the number of papers in that list that went to the BMJ and got desk rejected, and the number of papers that went to the Journal of Advanced Nursing and got desk rejected. And you have to just say, it's not personal to me, it's just that it's not the right fit for that journal, but it will be the right fit for another journal. So just carry on, just persevere. And the other thing is to not take any criticism personally. My own experience is that it's okay to rage against the reviewers when you get the comments back. Sit on them for a week, go back to them, look at them with a different eye, and accept that most of the time that criticism is probably justified. You probably could have explained something a bit clearer. You probably could have addressed something slightly differently. And almost definitely, if you take those comments on board and revise your manuscript and resubmit it, it will be a better manuscript. So I think it's just trying to accept that this is part of the process, that I still put papers in that come back with reams of comments and revisions that I have to do in order to get something submitted. It doesn't suddenly become easier. It's just, I think you just get more used to expecting that that's what's going to happen, and you're pleasantly surprised if it doesn't. So I think it's having a mindset of expecting that and just accepting it's part of the academic process, that we, all the way through my career, every grant has come back with comments, revisions. Some of them get funded, some of them don't. Papers go in and they come back with comments and suggested revisions. Most of the time they'll get accepted somewhere, but it might be the third journal I've tried, it might be the third revision. So it's just accepting that's part of the process.
Yeah, absolutely. Perfection is the enemy of progress.
Indeed.
Well, I think that brings us to the end of our interview today. Dawn Dowding, thank you so much for speaking with us. To our listeners, thank you so much for choosing to join us for Humans of Clinical Academia. This is a Manchester Catalys podcast. Manchester Catalys is a partnership between the University of Manchester and Manchester University NHS Foundation Trust, and we are grateful for their support, which has made this recording possible. I'd also like to thank my Manchester Catalys colleagues, and especially Umang Sinha for production and editing and help today.